Fantastic. So we're now live on YouTube and Facebook. So my name's James Bagley, here from School of Global Affairs, actually in the building for one of the few times in recent months. And this is the first event in what is going to be an ongoing series for global health and social medicine here at King's College London. The series Age of Health will aim to explore how health came to define our social, political and economic lives. And it will look at lots of different things, but initially we are going to be focusing on the COVID-19 pandemic, its impacts, its effects, and some of the ways it's allowed us to reflect on where we're at in terms of health, and also the ways in which health intersects with different elements of our lives. I think global health and social medicine has been doing a lot, it's been speaking about a lot of the issues that we've suddenly become aware of in the last few months. And so it's really fantastic that the department is going to be kind of having this conversation, and it's going to be available to the public, not just today. So you're watching live, but this is also going to be available on an ongoing basis. And we hope it can be a real resource for communities and for the public at large to help us understand some of these big challenges we face, not just during the pandemic, but also afterwards, and how we think about how we build health systems and society more broadly. Our first webinar is being hosted by the fantastic Dr. Hanna Kienzler, who is a reader in global health and director of the undergraduate program in global health and social medicine here at GHSM at King's. She completed her PhD in cultural and medical anthropology in the Department of Anthropology and Social Studies of Medicine at McGill University in Montreal, Canada, and now is obviously based here at King's. Hanna is going to be speaking to us today about many issues, and I'm really looking forward to it. So without further ado, Hanna, I'm going to hand over to you.
Brilliant. Thank you very much, James. Thank you for everyone who is joining and about to join this first session. I will be speaking about pandemic reckonings, reparations, and restorative justice in the wake of COVID-19. I'm going to share my slide and present for about 20 minutes, half an hour, and then we'll have plenty of time for discussions and questions, something that I'm really looking forward to. So I hope everybody's able to see my screen. If you can't, James, just let me know. So I'm going to just jump right into the talk that I prepared, but not without also reflecting about my own position vis-a-vis the topic that I'm going to speak about. So I'm an anthropologist by training, as James already mentioned, and I research health in war, mental health in context of war and conflict. I conduct research amongst survivors of war, as well as mental health practitioners in Kosovo and the occupied Palestinian territory, as well as amongst refugee mental health here in the UK. So you might wonder, why is she talking about the pandemic in the UK context? But what connects my work in these different contexts is the politicization of health. That is, I understand health as fundamentally a political matter that requires, besides medical diagnosis and treatment, also political interventions rooted in equity and justice. So in my talk today, I will apply this understanding to the coronavirus pandemic with a focus on racial inequalities and injustice in the UK context. While the talk will be rooted in emerging health data, it is also a think piece in which I reflect on possible ways to achieve health equity through restorative justice and reparations from a self-declared perspective and position of privilege. So my position of privilege comes with limitations. I cannot and I will not speak for those whom the society has marginalized and exploited. I cannot and I will not claim the status of expert by experience. And therefore, I cannot and I will not present you with solutions to the problem, as I believe that solutions to achieve health equity and justice have to be developed with those who have been wronged in the position of leadership. What I can do is, however, highlight, based on available data, the health injustice in our society and provide an interpretive framework that questions privilege and allows for the dismantling of unjust power structures. The COVID-19 pandemic has highlighted the vast inequalities within our health and social care system. It also highlighted how racism, both contemporary and historic, has direct and ongoing implications on the lives and well-being of those living today. But can the pandemic mark a moment of real change? In this talk, I will explore this question by giving an overview of the emerging data that highlight the differential impacts of the pandemic, with a focus on ethnic and racial disparities. I will outline some of the underlying drivers of structural inequalities, and then sketch a path forward based on social justice. So let's start with some of the overview. In order to investigate ethnic and racial inequalities in the wake of the coronavirus pandemic, I will be looking at mortality rates overall, and then specifically by focusing on different criteria, such as age, gender, and ethnicity and race. So between November 2020 and February 2021, COVID-19 was the leading cause of death in both England and Wales. Latest Office for National Statistics data indicate that thanks to ongoing vaccination efforts and other public health measures such as social distancing, the situation is improving. As it stands, COVID-19 was the 24th most common cause of death in England and the 31st most common cause of death in Wales in May 2021. The proportion of deaths amongst those most affected, people aged 75 and older, has also decreased steadily. Mortality rates have not been distributed across society, though, and data indicate that we are clearly not in the same boat. With regards to age, older people in care homes have carried the brunt of the burden, with extremely high mortality rates, which led many of us to question our relationship to age, as well as our elders. With regards to gender, we know that mortality rates were 18% higher among men compared to women, a difference that was even more pronounced at the beginning of the pandemic, when 30% more men died compared to women. When we turn our attention to social, economic, and environmental factors, there are differences, particularly for Black and South Asian groups, as well as other minority ethnic communities. In the first half of the year, the likelihood for Black, African, and Caribbean people to die from COVID-19 was approximately 2.5 times higher than for people from white ethnicities. The fact that significantly more people from Black, Asian, and minority ethnic groups are dying from COVID-19 has led several scholars to argue that we're dealing with more than just a virus. The author and political activist Arundhati Roy asked, "What is this thing that has happened to us? It's a virus, yes. In and of itself, it holds no moral brief, but it is definitely more than a virus." What we're witnessing is the exposure of structural inequalities that shape our society, structural inequalities that were conveniently ignored by those in power for decades. However, before examining the underlying structures, it is worth spending more time or some time with the available data on ethnic and racial inequalities based on updates by the Office for National Statistics data. So based on these data, we can learn that during the first wave, so from January 24th to September 11th, 2020, people from all ethnic minorities had higher rates of death and related to COVID-19 compared to white British people. The rate of death was highest amongst Black African groups, in fact, 3.7 times greater for men and 2.6 times greater for women. During the second wave, so from the 12th September 2020 onward, the difference in COVID-19 mortality compared with white British people increased for people from Bangladeshi and Pakistani backgrounds. For Bangladeshi men and women, to die from COVID-19 was respectively 5 and 4 times more likely compared to white British people. The mortality rate for people from Black, African, and Caribbean backgrounds also remained elevated. Further, the UK's Intensive Care National Audit and Research Centre has reported that critically ill patients come disproportionately from Black, Asian, and other minority ethnic groups. On May 1st, 2020, it was reported that 2,300, so 34%, of patients were from ethnic minority backgrounds who suffered from COVID-19. So for comparison, the 2011 census indicates that 14% of the British population is from ethnic minority backgrounds. So the disproportionate effects of critically ill COVID patients in the clinics becomes really quite starkly apparent. There is also the fact that NHS staff from ethnic minority backgrounds were disproportionately affected by COVID-19. The scandalous fact that the first 10 doctors who died were Black, Asian, and ethnic minority from ethnic minority backgrounds led the British Medical Association to investigate these unequal vulnerabilities. So what is driving these health inequalities along ethnic and racial lines? The Harvard-based historian Evelyn Hammond has recently stated in an interview that epidemic diseases such as COVID lay bare and make visible inequalities in society. These inequalities, she states, are not new developments, but are rooted in the history and form part of our very fabric of social life of our society. As they are structural in nature, they're often invisible to those who benefit from them. So why is it that these inequalities have become visible not only to those affected, but also to those in positions of privilege? Arundhati Roy suggests that it is because we begin to recognize that inequalities affect all of us. She writes cynically but aptly, now in the era of the virus, a poor person's sickness can affect a wealthy society's health. I want to explore the drivers for these inequalities further by returning to our data from the National Office of Statistics. So these data related several factors to the ethnic and racial disparities. First of all, it was recognized that some minority and ethnic groups have greater risk to get exposed to the virus due to their work and working conditions. Just over a quarter of the Black, Asian, and minority ethnic groups make up the healthcare professions. Among them, people also from these communities are more likely to work in sectors and professions that have been shown to be at higher risk to contracting the virus, such as public transport, retail, care work, security, and cleaning services. Some people of minority ethnic backgrounds have also been segregated in deprived areas, in overcrowded urban housing centers, and work in overcrowded workplaces, where social distancing or social isolation are almost impossible. Moreover, people from minority ethnic backgrounds appear more likely to live in multi-generational households, which put especially older family members at greater risk of exposure to the virus. Other risk factors that have been identified were biological in nature, including chronic illnesses or conditions, which appear higher amongst people from Black, Asian, and minority ethnic backgrounds in comparison to the white British population. However, Such biological interpretations have been questioned as they lead to misinformation, prejudice, and racism, othering the bodies of those who are already marginalized in society. Rather, it is widely recognized that the biological risk factors are caused by and reflective of the social and economic disadvantages connected to racism, exclusion, and insecurity. As already mentioned, these inequities and their impact of on life and death are not new. Speaking again with Arundhati Roy, she says, the tragedy is immediate, real, epic, and unfolding before our eyes. But it isn't new. It is the wreckage of a train that has been careening down the tracks for years. This wreckage of a train has been named injustice, structural inequalities, and structural racism. The train wreckage has a long history directly linked to colonialism and its inherent violence, exploitation, and deprivation of entire population groups, both in the colonies and here as people moved to the UK to boost the local economy and our health system. The train wreckage also links to newer historical developments, such as the so-called hostile environment that migrants and refugees are exposed to. A mental health worker supporting refugees told my research team recently, and I quote them, social exclusion means lack of access to statutory services, such as housing, such as benefits, such as education. Social exclusion is a massive barrier to do anything really. It means being stuck, actually. The person went on to explain that such exclusion leads to anxiety, depression, hopelessness, and despair, as well as deteriorating physical health. Political exclusion, political hostility, social exclusion, prejudice, and racism have long been shown to grind away people's health and well-being, while they benefit those of us in privileged social positions. A privilege that we are made to feel is unquestioningly natural and deserved due to our education, hard work, and industriousness. It does not occur to us that our privileges come at a cost, that our privileges are directly related to the exploitation and exclusion of others, all the while we benefit from their services that have pushed them to the front line of the pandemic. So, where to go from here? If we agree that the underlying reasons for ethnic and racial health disparities are structural and pervasive, then the solutions need to be equally structural and pervasive. So my argument is inspired by an article written by Krishnan and colleagues called Historical Insights on the Coronavirus Disease 2019, the 1918 Influenza Pandemic and Racial Disparities, Illuminating a Path Forward. Although the authors are drawing on examples from the US context, their proposed path forward appears mostly apt for the UK context as well. The authors divide the path forward into three segments which I wanted to explore in greater depth in the remainder of my talk. So they're looking at the early pandemic response, the middle pandemic response, and then the long-term pandemic response. Let's start with the early pandemic response. Krishnan and colleagues call here for the transparent communication of accurate information based on data of disease incidents that are stratified by key demographic factors, including ethnicity and race. In this and past pandemics, disinformation based on poor data quality and lack of disaggregation has led to racist health myths. And such myths suggested, for example, that Black people might be more immune to a disease or particularly vulnerable and thus a danger to the rest of society. The consequence was victim blaming, othering, and outright racism. The middle pandemic response, Krishnan and colleagues explain, should focus on policy initiatives that address the social determinants of health before pandemics even arise. They promote a kind of health in all policies approach where social services are well integrated into the health system response. In terms of pandemic preparedness, they argue, they highlight the importance of putting resources aside so that increased social support can be provided to those most in need during and after the pandemic. With regards to the long-term pandemic response, the authors highlight the importance of following a restorative justice approach. This is what I find most interesting. Restorative justice has been defined in various ways. One is provided by Carolyn Boyce-Watson, who considers it a growing social movement to institutionalize peaceful approaches to harm, problem solving, and violations of legal and human rights. Such approaches can include international peacemaking, such as tribunals, and innovative ways to reform our criminal justice system or schools or social services. Such approaches engage not so much the law as they involve those who were harmed, as well as the wrongdoers and their affected communities, in search of solutions that promote repair, reconciliation, and rebuilding relationships. So in other words, it requires restitution with input from both victims and offenders. Thereby, offenders have to learn and admit to the harm they have caused in order to be able to become part of the solution, while giving up privilege in order to allow those whom they have pushed to the margins to play a central role in agenda setting and policy initiatives in ways that acknowledge their contributions. Krishnan and colleagues argue that acknowledging the structures that contribute to disadvantage in our communities needs to transcend into concrete measures, which mirror pretty much those that Sir Michael Marmot has proposed for the UK context. So in his Build Back Fairer report, he highlights structural racism and emphasizes the overwhelming need to deal with such racism in combating the social determinants of health inequalities. Overall, tackling social determinants requires starting with those most vulnerable by giving children the best start in life, enabling young people to maximize their capabilities and control their lives, creating fair employment and good work for all, ensuring a healthy standard of living for all, creating and developing healthy, sustainable places and communities, and strengthening the role and impact of ill health prevention. Each of these areas carries equal importance, equal weight. They have to be invested in and worked on simultaneously. You cannot prioritize one over the other. But a focus on social determinants is not new as such. In fact, many of us have been calling for greater attention to social determinants of health, including poverty, employment, education, gender-based discrimination, and other forms of discrimination related to racism and xenophobia. And we have called for that since quite a long time. However, what this call has been largely missing is a real upstream political agenda that has social justice at its heart. In fact, it tended to deflect responsibility as it focuses on deprivation rather than the consequences of unjust privilege. So, and this brings me to the heart of my talk, a call for reparations as start of an ongoing pandemic response. A restorative justice approach further requires not only recognizing one's own wrongdoing and working to improve structures to achieve greater quality, but also to make amends is for having actively held people back from flourishing. Bassett and colleagues have considered reparations a public health issue, that if we agree that forces that shape our social structure and our health are directly connected to the unequal distribution of power, money, and access to resources, then reparations could have the potential to target some of the underlying causes. The authors highlight 3 pathways of how reparations could help us break with the past. First, expanding resources and making them available to disadvantaged Black, Asian, and minority ethnic groups could close the health gap by giving people the opportunity to afford living in better neighborhoods, sending their children to better schools, and access cleaner air. Second, reparations would help to reduce stress, which has been linked to poor physical and mental health, as well as difficult social relations and family dynamics. And then third, reparations would have an intergenerational effect, as health is produced over the life course across generations. So reparations made today would be an important investment into the future, not just for those directly affected, but for all of us, as ample evidence exists that more equal societies are overall better off, are healthier, and have longer life expectancy. Thereby, it is important to recognize that reparations alone don't solve racism, while restorative justice, without the willingness to make amends by giving up privilege and sharing resources in ways that recognize past wrongs, also be insufficient. The solutions have to be achieved together with those most affected in the position of leadership. I'm convinced that it will take tackling deep-rooted injustice, an anti-racist agenda, and social justice approach to achieve health for all during and in the aftermath of the pandemic. I will leave you with another quote by Arundhati Roy, who writes, "Our minds are still racing back and forth, longing to return to normality, trying to stitch our future to our past and refusing to acknowledge the rupture. But the rupture exists, and in the midst of this terrible despair, it offers us a chance to rethink the doomsday machine we have built for ourselves. Nothing could be worse than a return to normality." Thank you.
Thank you so much, Hannah. That was fantastic, and sort of lots of thoughts and questions spinning around. I should say that if anyone who's watching on the Zoom would like to ask a question, please do put them in the Q&A function, and we can raise those questions there. I guess just to kick off, really where you ended, but while it's fresh in our minds, about reparations, and obviously a key part of the webinar that you've given. I mean, and I guess it connects to a lot of what you said. I mean, how far do you feel that the health and health systems can operate as a kind of vehicle for fixing wider problems? So how much should we see it as actually not just, you know, these being kind of warning lights on the dashboard, but actually that it kind of can operate backwards, so that if we can fix some of these health challenges, maybe that's an easier way to fix some justice questions around racial justice that seem kind of impossible to solve at the moment?
So that's a good question. Thank you. I suppose there is no easy fix. We're dealing with really complex structures that we let grow over decades, over many years. So the approach has to be pervasive. The approach cannot be on the surface level. By dealing with health, these kind of inequalities will not go away. But where health, I think, offers an interesting segue in, on the one hand, it is a bit like a mirror. It reflects back the state of our society, and that is what is happening right now during the COVID pandemic. At the same time, health is more than a medical issue. In our department, Global Health and Social Medicine, our slogan is health is more than a medical matter. So I'm quite convinced that we can only achieve health through an intersectoral approach. I can only address health if I'm also dealing with social injustice, if I am dealing with a social service, housing, education, work, and other fundamental issues. So this is called a health in all policies approach, where if you make decisions in the completely different sectors, you have to ask yourself, in what ways will this affect the health and well-being and quality of life of the people who will be affected by this policy? And that can be in the sphere of transport, education, housing, whatever. So this is how I understand health. It is, on the one hand, it is a mirror, but it is also part of everything that we do. So social justice has to permeate every aspect of society, every sector of society. And only if we allow for this to happen, will our health also improve. Not just among those who are most vulnerable, but actually for all of us. And research has shown that quite clearly.
Actually, for those of us that don't work in the health sector, actually just thinking about health whenever we make these decisions sounds like a really good way for us to remember that one. So just a question here, and a few people have got their hand up. If you do put your question in the chat, because then we can ask them. But Nirjan asks, what are the implications, and you mentioned there about health professionals, but what are the implications for the medical profession, given that there are major disparities there in terms of outcomes for minority communities? So kind of what are the implications there for the medical profession, do you think?
Again, a hugely important question. And I think what we need to realize is who is working at the front line. So these are health workers, but of course we see it also in other sectors of the society. I think in the field of health, it is just so shocking to see that most deaths occur amongst Black, Asian, and minority ethnic groups. But the same is true whether we think about the care sector, housing sector, cleaning sectors, etc. So where we sometimes pay possibly less attention depending on our own positionality in society, and because we believe that health and the health sector should be a safe space. And again, there are structural issues and questions to ask. So who is working? So really identifying who is working in the health sectors and how do we support them in ways that do not put them into harm's way. And that requires, I believe, to also again look beyond the health sector, where we understand people much more holistically, understanding where they're coming from, their living conditions, their family lives, etc. To not just have the kind of downstream interventions to provide more and quicker and adequate PPE, of course, hugely important. But then thinking about how else to protect people and their families, because it's not just these health professionals who are more affected, it's also their families, the various generations that might be living in their households as well. And so again, I would say a holistic approach and really understanding a person as more than a sort of two-dimensional being or just through their work will be hugely important.
Fantastic. So a great question from Jordan here. Mentions that fabulous presentation. And he says that, can I ask about reparations and what these would look like? And I know you gave some examples, but I think he was asking for more information. And he does say the idea of reparations is, of course, a loaded one that relates to the payback in post-colonial context, and particularly for those of African descent, for the atrocities of slavery and unpaid labor. How do reparations for racialized health inequality work?
So it's a complicated question, and I will say from the start that I don't have the answer, but that there is also a good reason of why I should not have the answer. Nevertheless, the historical connection that you are drawing, especially to slavery and colonialism, is absolutely right. But I believe that slavery and colonialism are not just something that is somewhere in the past, but that we're dealing with the consequences today, the way we relate to one another, the way society is structured, the way that privilege is structured, the way that we manage to live our privileged life without thinking about these connections ever, except if you have been affected by them in negative ways. Whereas if you have been affected by them in positive ways or in privileged ways, then it is quite easy to ignore them, not even know about them, or unknowing them. So really pushing them to the back. Ways in which reparations should be paid is, first of all, I think, it comes again with the restorative justice approach. First of all, you have to acknowledge the wrongs that you have been doing, the wrongs of your privilege that put you in a position that allowed you to benefit from exploitation and the active marginalization of other people. And then it is a working together. It has to be a participatory bottom-up approach where it is about listening, where it is about supporting, where we would need to hear about what it is that communities would want to have in terms of reparations, how these reparations should be delivered, and how they should be used and distributed amongst the communities. So they, not just as individuals, but actually communities can flourish in the way they wish to. And for those of us in privileged positions, besides listening and really hearing, there's a difference between listening and really hearing, really taking it in, it is then important to make space at the table for people most affected to lead that process in collaboration and support with others who might be more traditionally in power structures. So again, there is not a quick fix. It might not be simply a material fix, but it is as much material as it is social, as it is symbolic as well. So these three things, I think, need to come together, but through a participatory approach, where also the labor of those who are most involved in trying to change and dismantle power structures is really acknowledged, because oftentimes their work is just heaped on top of the work that they're already doing without getting acknowledged for what they're doing. And again, the privilege dominates in the way we are working. So sorry, not a quick sort of answer or clear answer, but I do believe it has to be participatory, and it is specifically not up to me to decide what should happen.
Yeah, and all through the talk, you've recognized your own positionality in this, and that's I think that's really come across. I mean, just to follow up there, I mean, you mentioned how key it is that communities are actually involved in shaping health systems, or that communities are actually without them, none of this can be achieved, that actually it should be led by those that have been most affected. And then again, you know, not loading it onto them. So I guess there are ways in which those with privilege can form some ways of solidarity, or utilizing their position to support those that do need to be heard. Are there ways for that to happen, do you think? And should we be making kind of, should we be creating vehicles for that kind of, I guess it's a form of solidarity, or at least support for various different groups?
Yeah, I believe that this labor we cannot suppose that this labor will be given for free or should be given for free. Oftentimes, political activism is considered something that you do on the side, that you volunteer to society. I think this is such a huge job. It has to be remunerated. It has to be acknowledged in terms of position, in terms of space on the table of power. So I do believe that this kind of work cannot just be an add-on. It is hard labor. It is political work, it is social work, it is economic work that has to be recognized and, yes, remunerated, both materially, socially, and economically, if you like. And again, it is, yes, it is a form of solidarity, but it is one of stepping back from the limelight rather than into the limelight. Because sometimes acts of solidarity can again put those in privilege in the position of the limelight, that show how they're themselves again drivers of the agenda, whereas I believe that they should specifically not be the drivers of the agenda, that someone like me should not be the driver of the agenda, but rather supportive of those who are driving the agenda in ways that feel meaningful, that are meaningful for their communities, for communities that have been wronged for such a long time.
Yeah, so just a question here from Leslie about, and I think, so there's two parts of the question. So I'll ask the first part, and I think I understand what they're saying, but the is actually the discrimination shown towards migrants. So she gives the case, they give the case of Singapore, the housing conditions that caused an outbreak. I think there are other cases that can be pointed to where actually health workers are being discriminated against because they are migrants. They are then actually more likely to catch the disease, but actually also more likely to the diseases that actually by having these discriminatory policies are actually worsening health systems and things like that. So can that be the direct link really? Is discrimination, I don't want to say is discrimination causing COVID, but is it making it worse? Would that be a fair statement?
I would say that it is completely a fair statement, because we are protecting populations and different groups of people in different ways. Some people we are more willing to throw under the bus in order to protect, again, others. And I do believe that when there is discrimination in a health system, it will be more difficult for those who are discriminated, for example, to ask for additional PPE. That there might be also an internal stigmatization where they feel like they're not deserving of it, or they're afraid that there will be a backlash against them for wanting too much, for requesting too much. And so will be less protected. Also, when I was talking about these racist health myths that have been circulating also during COVID, but also when I think about the article from Krishnan, who have shown that similar health myths that floated around during the COVID-19 pandemic were already in play in the 1918 influenza pandemic in the US, that showed that certain groups of people, in this case it was African Americans, were considered to be less prone to catch a virus and therefore were pushed to the front line, assuming that they would become less ill due to the virus. And that, of course, not only affecting those populations disproportionately, but also affecting the rest of the society. And here you can see how an inequality, discrimination, and racism is not just bad for the communities and at the front line of it, who carry the brunt of the burden, but actually for the entire society. So discrimination, systemic discrimination, hurts everyone, although of course some groups are much more affected by it, but it affects everyone. And it requires a systemic approach to dealing with it. So again, to reiterate, a more equitable society will overall do better. So tackling racism is good for all of us.
I mean, Ilana raises a really important point, and actually something that I've sort of seen elsewhere so they've said what precisely communities are, and who is speaking for them. Not all the people in the communities have the same interests, and sometimes spokespersons for communities fail to represent sectors of this community, whatever the community might be. And I think that's so important to raise, because often these are kind of the NHS, for example, has vehicles for people to sit on boards, so kind of patient boards, but the types of people that are able to actually sit on those boards, or even those who put themselves forward from any one community, may be a certain type of person. So, how important is it to think about that? I guess to add to it is, how do we overcome it? Or again, another really big question, but.
Yeah, no, I'm thankful that this question has been asked, because I have been thinking about this while I was preparing the talk myself. One of the criticisms that I had, that other people had, that many people had, was even under the label of Black, Asian, minority, ethnic. So what is this supposed to be in the first place? It's not a homogeneous community as such, nor are Black, Asian, minority, ethnic communities homogeneous in and of themselves. They are stratified according to various lines, also of power and privilege. As you are rightly saying, because they have different positionalities, they also have different interests, different vested interests. Those with the loudest voice might not represent the views of others in their communities, or even of most of their communities, but due to their positionalities, they have more voice, they're easier heard by those in power and also privilege. That has to be really taken into consideration when thinking about how a community bottom-up response would look like. To think about what are the different groups, what are the different identities within these groups, what are the hierarchies within these groups, what are the conflicts within these groups. Obviously, there cannot be one token person to represent everyone. They can speak for themselves and maybe their sort of wider network. So this has to be done carefully, with real awareness of internal diversity, conflicts, power dynamics, etc. And because otherwise, if that was not the case, we would just be perpetuating the situation as we have it. Again, I don't have a proper answer to this. But I believe that these questions are important, and we need to continue asking them, to always ask who's representing, whose voice counts, who speaks for who, and who is again and continues not to be heard, whose needs are not being met, who is again being pushed to the margins, and how can we avoid that? How can we create a more equitable society in the real sense of the word? And it requires exactly asking these kind of questions and making demands for transparency.
And I guess final two questions. The first one, just to pick up on that point, and maybe it is because we're talking from a position of global health and social medicine, but I guess how important is it, do you think, that we do break down the barrier between sort of health and wider issues in society, and think about these, not just, and sort of remove that, not just because it happens a lot in academia. I think if anyone's worked at university or worked around research, actually interdisciplinary work is quite common, and bringing various different research areas together. But is that something that we now need to do in government, that governments need to do, but also local authorities, councils, organizations, that they need to bring people together from different areas to really solve these challenges?
Yeah, I believe there is no other way. And I think in academia, we're not actually particularly good at that. We're good at talking about interdisciplinarity, but doing real interdisciplinary work, we're not great at that. There's often respect lacking, again, power dynamics at play that get into the way. It's very difficult for us as academics often to pull on the same side of the string. So again, also here in academia, I do believe that we need to rethink the way we look at societal problems, that they cannot be addressed in silos, but that they have to be addressed through an interlinked way. And only by understanding that health is as much about education, employment, housing, gender, race, and ethnicity, and that the health professions cannot solve these issues on their own. So when it comes to departments, government departments, etc., if the health sector is siloed, it will not do the work it should be able to do. Obviously, health providers can't be everything. They cannot be the housing association and the education sector all at the same time. But what they can do and should do is build these linkages between these sectors, who should all understand that if they work towards improving health, their own sectors would also flourish in a better and more equitable way. So that they're not, so it needs to be understood that if health is really central, everything else will improve as well, because otherwise it will be difficult to get buy-in, to get the transportation sector to recognize that they need to pay attention to health and actually invest into health when they feel like nothing, they're gaining nothing. So I think making systems and sectors understand that by working together, everyone will gain. That is the trick, but that is also, yeah, the difficult part to achieve, to get everyone onto the same side, while not losing complexity either. So I think debate is important, questioning is important.
Just finally, your webinar has alluded to Arundhati Roy's piece in the Financial Times, which I would urge everyone to read, and maybe we'll put it in the notes in the YouTube recording. And pandemic as a portal, and just as portals can open, they can close. And I suppose as we come out of the pandemic in certain parts of the world, if the vaccine rollout continues to go well, you know, is there a chance that this opportunity can be missed? Will the portal close and we can't reopen it? Is it important? Can it be held open by communities, society, or is the reality that the pandemic isn't just going to go away? COVID is going to be a background noise to our lives for years, perhaps decades to come, and in fact that will maintain this portal into trying to make change.
Yes, I do believe the portal can close. I'm not that optimistic. I would want to believe that the portal is open and we could walk through it in a different way. But I do believe people are actually quite connected to their privilege and are not ready to give it up. And the current international vaccine rollout shows this very, very clearly, where vaccine nationalism dominates, where COVAX, where COVAX is very difficult to achieve, where it's about hand-me-downs from rich nations, where it's about charity rather than equity or solidarity or justice, where it is not recognized that until we're all vaccinated, until we're all well, right? And if that is not possible on this large scale, where we really had the opportunity, and it's not too late, possibly, but I think the fight for this is real. And if we're slacking off, the portal will close and we'll be back in the old structures that have served the elite very well. And they wouldn't mind if it would continue to serve them in the years to come. So I do believe that we have to keep making the situation uncomfortable. Otherwise, the portal will close.
Well, that's a kind of call to arms, I guess, and it's a good place to finish. as I say, these conversations are going to continue as part of the Age of Health series, and we hope that we can share this knowledge and share this expertise that will be useful in many ways, we hope, to start a conversation, to add to the conversation that's ongoing. I should, to promote our next event, will be happening on the 8th of July. If you head to the Global Health and Social Medicine website, that we're going to be having a panel discussion about how COVID-19 has highlighted the social determinants of health, some of what is mentioned in Sir Michael Marmot's report, who he's been speaking about for a long time, and this pandemic has highlighted that. That event's going to be chaired by a professional in Ash Sarkar, who will be asking wonderful questions, I know, along with a colleague from Harvard, Professor Michelle Morse, Professor Barbara Prensack, Professor Anne Pollock from here at King's College London, and Dr. Carlo Kaduf. So it will be a really fantastic discussion. It will bring an end to this year before we go on a break for the summer, and we'll be coming back with more discussions in the autumn. But until then, Hannah, thank you so much for the webinar. It was fantastic.
Thank you very much for having me and for joining.